about epigenetics and the SIMP pathway as it's gotten to be known, um, and then end with sort of wrapping all of these processes into what is known as the molecular classification of colon cancer. And hopefully we'll have time for, I think I have 4 or 5 questions at the end that touch on all these concepts and hopefully will help you remember key take-home points of this talk. The epidemiology part should be fairly familiar to all of you, and I'll try to move through this section quickly. If you don't mind muting your microphone, I think there's somebody whose microphone is unmuted.
I can talk to them.
All right, let me.
I think that's you, Amy. There you go. So the main statistics that I'm sure all familiar with is that the lifetime risk of colon cancer for an average individual in this country approaches 6% or about 1 in 20. When both genders are taken into account, it's the second most common cause of cancer death in the United States after lung cancer. And globally, it's also a significant contributor to cancer death, being the 4th most common cause of cancer. In aggregate, all GI cancers are the #1 cause of cancer death in the world. What it means is, just to put this into perspective, UT Southwestern, as of a couple of years ago, had graduated over 11,000 physicians since its founding. And these statistics would mean that close to 700 of them probably will or have had colorectal cancer. So this is not a rare disease in any way. Now, CRC incidence and mortality are declining in the United States. You can see here on the left the trends over the last 10 years. And on the left, the incidence every year has been dropping, and so has the mortality, although in other parts of the world, incidence and mortality are still on the rise. This is a temporal trend. Oh, sorry, something happened here with the formatting. This is on the right. Maybe I can get a laser pointer. There we go. On the right, you can see the temporal rate of incidence and mortality in the United States, which is dropping, more so in whites than in blacks, but it's dropping in both. And similarly, a reduction in mortality, not just in incidence. In other developed countries are following similar trends. The exception to this behavior has been in the young. So while overall incidence is dropping and incidence of cancer over the age of 50 is dropping in the United States, incidence of early colon cancer under the age of 50 is actually on the rise. And it's on the rise in a fairly significant way in the last 20 years, not just in the United States, but also in other industrialized countries, pointing to some environmental exposure to this cohort of individuals who are coming of age now. In a lot of research into what environmental exposures might account for this rise in early or young adult colon cancer. Now notice that the y-axis is dramatically different. So this is not the majority of cancer, but it is on the rise and of some concern. The risk factors and protective factors associated with colon cancer include, and I've listed them here in order of, say, strength. So on the risk side, there are well-defined cancer genetic syndromes with very, very high risk, sometimes approaching 100%. There are other diseases with known increased risk of cancer, such as inflammatory bowel disease. Family history increases your risk of colon cancer. And then there are demographic and dietary factors that also affect your risk of cancer. Whereas on the protective side, there is screening, the use of aspirin, exercise, and certain elements of your diet, which I'll briefly review for you in a moment. So among strong risk factors, we all recognize that there are genetic conditions in which um, typically tumor suppressor genes are inactivated, leading to a substantial increase in the risk of cancer of the colon. And in the syndromes, usually other organs are also involved. There's an entire lecture on cancer genetic syndromes um, that um, is will be given at another point or has been given already. So the point of this is just to remind you, these are the strongest risk factors that we know of when patients are identified as having Lynch or FAP and so on. Depending on the syndrome, the lifetime risk can increase from 6% to 30% or even 100% as in classical FAP, which invariably by the age of 45 to 50 leads to colon cancer, if not prevented by colectomy. In today's clinical practice, if colon cancer patients undergo germline testing, about 15% will be found to have a pathogenic mutation. And we'll go into more detail into what that means in a moment. But of all the syndromes, the most common in this category would be Lynch syndrome, which accounts for 5% of all colon cancers. In Lynch is also the most common cancer genetic syndrome, present about 1 in 300 or 1 in 250 normal individuals, otherwise not normal individuals. So very, very common condition. In terms of the strength of risk, inflammatory bowel disease historically has been viewed as a moderate to high risk predisposing condition. But the numbers from older studies, which quoted anywhere between 3 to 10-fold increased risk of colon cancer, are dramatically lower in more recent studies, including some studies that don't find an increased risk of colon cancer. And this is likely due to the success in controlling inflammation, such that the risk is estimated to be lower, probably in the 1.5, 2-fold in more modern series. Note that inflammatory bowel disease being much less common, it only accounts for about 1% of all colorectal cancers that are linked to IBD. So just keep that in mind. Non-syndromic family history, depending on the number of relatives, their age at the time of diagnosis, can also increase your cancer risk anywhere between 1.5 to 3.5-fold. What that means is 1.5 would be going from 5 or 6% to 7.5, 8.5% lifetime risk. Up to 20% of colorectal cancer cases have a positive family history. So of all the strong risk factors, is probably the most common that we encounter. There are dietary effects on the risk of cancer, and these have been identified in hundreds of various studies linking diet to risk. Probably one piece of data that makes this case very clearly is comparing the CRC incidence in African Americans in the United States with populations of similar genetic makeup in Africa. For example, one can contrast the CRC incidence in the United States, which is in African Americans, which is between 50 and 60 per 100,000, to the CRC incidence in South Africa, which is less than 5 in 100,000. So there's a more than 10-fold increase in CRC incidence in two populations that are genetically not that similar, pointing to strong environmental factors. Same is seen when populations from Africa in more modern times migrate. So first generation immigrants or second generation immigrants from Nigeria, for example, or other African countries, when they come to the United States, they quickly equilibrate with the high incidence rates that are observed in the US and away from the low incidence rates seen in Africa. So This points to strong environmental effects. The main factor that has been assumed in this context is diet, but by no means is the only one. There are a number of other exposures that could be playing a role as well. Uh, Among studies looking at dietary factors that affect risk, it's been identified that red meat, high red meat intake, low fiber and low calcium are associated with higher risk of colon cancer. Demographic and other risk factors that are worth remembering. In general, the rates are higher in men over the age of 60. Among ethnicity or racial background, African Americans have a higher rate of colon cancer than whites. We talked about how country of origin, if you're an immigrant, can have a significant impact. But as the next generation grows under the environmental influences present in the United States, those rates quickly equilibrate. Additional risk factors include exposure such as smoking, which increases your risk not only of lung cancer, but also colorectal adenoma and carcinoma, alcohol, and also obesity and diabetes. So metabolic syndrome increases the risk of a number of tumors, not just in the GI tract, but clearly increases the risk of colorectal neoplasia, adenoma, and carcinoma. Other risk factors which can have a significant impact but are less common in the population include history of organ transplantation, so the immunosuppression and the cause for transplant, both playing a role in increasing risk. As it turns out, organ transplantation alone is not a very strong risk factor, but it is associated with increased risk of colon cancer, particularly in the right colon. Acromegaly, and this is something that's a favorite in the boards, is a condition that not only results in increased growth and the changes in body habits that are characteristic of acromegaly, but IGF-1 being a growth factor also has an impact in cancer risk, particularly in the colon and the thyroid. So it's been estimated that it increases your risk anywhere between 4 and 7-fold. So quite substantial. Something that was not appreciated until recently is that cystic fibrosis is also a very substantial risk factor for colon cancer. Now that patients with cystic fibrosis have a much longer life expectancy, it's been estimated that the risk of colon cancer is anywhere between 5 to 10-fold in patients with cystic fibrosis, and that is substantially increased further by transplantation due to the combined effect of the disease plus the immunosuppression associated with transplant. Therefore, this is, for example, a population that receives a lot of attention post-transplant with regards to cancer prevention. On the protective side, probably the best studied are screening strategies, which have been shown to reduce risk of colon cancer. Screening colonoscopy, for example, has an effect on reducing the risk of colon cancer, particularly on the left colon, less so on the right colon. I would point out that older studies did not find any reduction on right colon cancer risk, but more recent studies, probably due to improvements in a number of aspects of colonoscopy performance, do show a more modest but significant reduction in cancer risk in the right colon. The other known factor that reduces risk of colon cancer is exposure to aspirin and probably to other NSAIDs as well. For example, the Nurses Health Study pointed out about a 20 to 30% risk reduction after about 10 years of exposure in average risk individuals. So this is well known and has to do with the important role of prostaglandins in the development of adenomas in early colon cancer development. Besides this risk or protective factors, it is known that increased physical activity as well as certain aspects of your diet, as pointed here in this slide, are also associated with decreased risk of colon cancer. Now, when one looks at the distribution of cancer based on known disease or genetic causes of cancer versus individuals who have colorectal cancer for whom no clear underlying risk factor can be identified. Historically, we used to segment the cases roughly as in this pie chart, with 20% with family history, 75% sporadic, and anywhere between 6 to 7, 8% with well-defined high-risk conditions such as Lynch syndrome and so on. In this day and age, if one were to perform genetic testing on all comers, we recognize that there are greater numbers of patients with underlying pathogenic cancer mutations that, due to their family history, would not have been picked up otherwise. So probably the breakdown is more as depicted in the bottom. 35 to 40% have an identifiable genetic or disease risk factor, with 60 or 65% still being truly sporadic with no overt risk factor for cancer. An example of the impact of universal germline testing on identifying potential genetic factors leading to cancer is depicted here. This is a study from the Mayo Clinic that just came out 2 months ago, where universal germline testing of colorectal cancer patients identified that about 15% of them had a well-known germline mutation in the cancer risk gene, some with high penetrance, including Lynch and FAP, others with moderate penetrance. These are cancer syndromes that have typically manifestations in other organs, but can include the GI tract. And so you will find about a third of these positive cases are with these other syndromes, and then a third with low penetrance or recessive cases. Okay. So genetics plays a role, germline genetics and environmental influences as well in the pathogenesis of this malignancy. Now we're going to switch gears away from talking about sort of talking about risk factors and how they may play into pathogenesis, and now get deep into the oncogenic process itself and sort of try to understand what's happening in normal cells that ultimately results in this entity that we call cancer. So the first concept that I want to bring to your attention is thinking about a tumor not just as a collection of neoplastic cells with mutations that are growing out of control, but as a tissue that consists of both neoplastic cells as well as non-neoplastic elements. The neoplastic cells, these cells that have accumulated genetic pathway alterations through genomic or epigenetic mechanisms that lead to the following tumor hallmarks: sustained proliferative signaling, resulting in uncontrolled growth, loss of growth suppressive signals that contributes to the uncontrolled growth, immortality. So cells normally have a number of mechanisms to undergo death when certain aspects of the life of this cell are not normal. And so all of these things are hallmarks that are present in the neoplastic cell. But the tumor is more just than its neoplastic element. non-neoplastic components of the tumor also play an essential role in the development of a cancer. And this is an area that, especially in the last 20 years, has received a lot of attention. So, for example, immune cells play both a yin and a yang sort of role in cancer, and that certain immune cells actually promote the growth of the neoplastic components of the tumor, whereas other cells in that environment can suppress tumor growth, and this is augmented, or the purpose of immunotherapy is to augment that response to control tumor. We also recognize that vascular components are essential to provide nutrients to the tumor, and angiogenesis is a critical target in the treatment of many cancers. It's not just the vascular component, but other elements in the stroma, such as the fibroblast, myofibroblasts, other cells can play a really critical role in sustaining the tumor and allowing it to evade the immune system, for example. In the context of colon cancer, surprisingly, because the microbiota can play a really, really important role. So this is a tumor that grows exposed to very dense microbiota, and there are complex interactions between these microbes and the tumor that are different than the interactions between microbes and the normal mucosa that can potentiate the growth of the tumor or its acquisition of metastatic potential, for example. So certain bugs associated with colon cancer and make it more metastatic, as an example. We don't have time in this lecture to go into the fascinating aspects of the non-neoplastic elements and how they play into cancer development, but perhaps at another time we can explore that. But that's really a fascinating side to this story. We're going to really stick to the classical understanding of what's going on in epithelial cells to turn them from normal growth to a neoplastic growth, and that's what we're going to explore. Now, before we get there, I just got to remind you that this is a process that takes place over time, and therefore we go from normal epithelium to carcinoma with intermediate steps or precursor lesions, such as your typical adenoma. And in this process, the number of lesions and what's going on earlier on is different than what an established tumor will have. So just briefly to remind you what the precursor lesions are, I just want to point out that there are two that are critical, and they are, in terms of the underlying genetic mechanisms, they can be segregated, as you will see, into two unique pathways. So the two most important precursor premalignant lesions are the adenoma and the sessile serrated adenoma. Even though the names seem to put them as cousins, histologically and molecularly, they're quite different precursor lesions that give rise to different types of tumors. Now, there are other tumors, there are other polyps that, although rare, also have clear premalignant potential, such as the traditional serrated adenoma, Poitz-Jager's polyps, and the juvenile polyp. I will not be discussing those in this lecture. Surprisingly, as you well know, small left-sided hyperplastic polyps are not themselves premalignant or associated with increased risk of colon cancer for patients that have a few left-sided hyperplastic polyps. But what is surprising is that they frequently harbor classically associated tumor mutations, such as mutations in KRAS. So not everything that carries a tumor mutation is necessarily premalignant, and there are reasons for that. So again, you are well familiar with what these polyps and these precursor lesions look like under endoscopy. I want to remind you what they might look like histologically. I know that this has been covered in your pathology or introduction to pathology lectures, but very briefly, an adenoma typically looks, it's a collection of neoplastic glands that are growing out of control. And one thing that is common is that they undergo something called mucin depletion, or the loss of goblet cells. If you look at this part, this is normal crypts of the colon. They have a lot of goblet cells. These ones do not. So they look bluer because there are more nuclei and less of these vacuoles of mucin. Sometimes these crypts have a villi-like appearance, and that's what it's called, a villus adenoma. As these lesions progress, the shape of the nuclei, their organization in the epithelium, and the presence of mitotic figures starts changing. They become less regular, and that's what's called atypia, and gives rise to the increasing grades of dysplasia. Unlike an adenoma, a sessile serrated adenoma, even though it has the name adenoma, really doesn't look like an adenoma that much or at all. It's typically located in the proximal colon, notoriously difficult to spot endoscopically, but histologically is most similar to a garden variety hyperplastic polyp. It has elongated crypts that the epithelial surface is not even. The cells have different heights and creates this serrated appearance to the border of the epithelium, as you can see here. Unlike typical hyperplastic polyps, the glands are not organized in a evenly spaced parallel fashion, but they have basal dilations or branching, and that's the distinction between an SSA and a hyperplastic polyp. As this become more advanced and cellular atypia dysplasia become evident. So it's no surprise that an SSA was only recognized relatively recently, the last 20 years. So this as a pathological entity was just beginning to be recognized in the 90s. Because histologically it's fairly similar to a hyperplastic polyp. And depending on the size of the specimen, sometimes these features may be missed. So it look like an SSA endoscopically, but the pathologist can't find the few crypts that make it so. Okay, an adenocarcinoma, just to remind you briefly, that the key distinction will be that these plastic-looking crypts have now extended beyond the muscularis mucosa and into the submucosa, as depicted in these two examples. Typically, this is associated with significant changes in the mesenchymal component or the lamina propria surrounding the crypts, and more significant atypia or dysplasia of those crypts. Okay, so what gives rise? We know that there's a process over time, that there are precursor lesions. They can be, the two main ones are histologically distinct. What are the genomic alterations that lead to the precursor lesions and ultimately to the tumors? That's what I want to review with you next. So there are two key pathways where the genome becomes progressively damaged, leading to the development of tumors. And these are divided into what is called the chromosomal instability pathway, which I'll explain what it is in a moment, and the microsatellite instability pathway. The majority of colorectal tumors display chromosomal instability. So this has something to do with the chromosomes. We'll get into that in a moment. Whereas microsatellites refer to genetic mutations in areas of repetitive DNA with chromosomes looking largely unaffected. So each one of these pathways is associated with specific molecular events, and they give rise to unique precursor lesions and tumor types. So what is chromosomal instability? I want to point here, show you here where a karyotype looks, a normal karyotype being on the left. Each chromosome has been color-coded or pseudo painted in a color, so you could, when there are chromosomal alterations that we'll see in tumors, you can see where the parts come from. So a normal karyotype is diploid. You have 2 copies of each chromosome, the larger chromosome being chromosome 1, and then progressively smaller from there on. A chromosomally unstable tumor is a tumor that displays aneuploidy, meaning it's not diploid anymore. For example, 4 copies of chromosome 7, 7 copies of chromosome 20, and so on. And at the same time, chromosomal rearrangements. So here you have a chromosome 3, which is actually a fusion with a piece of chromosome 2 and a piece of chromosome 8. So this is a classical example of chromosomal instability. And these wide rearrangements of chromosomes will lead to a lot of damage to various genes that are important in those in controlling growth and so forth and so on. On the other hand, microsatellite unstable tumors may have a lot of mutations in repetitive DNA, but are largely diploid with rare, if any, chromosomal rearrangements. And this is one example. The tumor is diploid. Maybe there's a chromosomal rearrangement, but that's about it compared to this one. Okay. So what drives chromosomal instability? This is a very complicated process, and not everything is fully understood, but we know that neoplastic cells, for some reason, tend to at first undergo genome doubling, meaning they become tetraploid. And there are some tissues that are naturally tetraploid and can be naturally tetraploid, for example, the hepatocytes. When you couple the tetraploid state of these cells with problems in DNA replication and mitosis, that is thought to give rise to aneuploidy and chromosomal rearrangement. So that many of these cells lack the fidelity of the replication process, leading to chromosome fusions, chromosomes that have 2 centers, so-called dicentric chromosomes. So when the chromosomes have to segregate during the process of mitosis, these dicentric chromosomes are very hard to separate, and they don't end up being separated evenly between 2 cells. Also, the mitotic spindle and its function is very abnormal in cancer cells, leading to missegregation in cells that don't get an even split of chromosomes. Moreover, the nuclear envelope in these cells doesn't form properly, and the DNA can be extensively damaged. Part of a chromosome sticking out of the nucleus gets extensively damaged and basically degrades, a process called chromothripsis, where that part of the chromosome is fragmented into so many little pieces that is no longer inherited into the next round of replication, leading to large chunks of chromosomes becoming missing in cancer cells. So very complicated process. Just remember, DNA replication and mitosis are very abnormal in cancer cells, and progressively the chromosomal copy number becomes quite abnormal. Microsatellite instability is driven by a very, very different process, which has to do with the loss of a normal quality checkpoint in DNA replication. So wherever there is a mismatch, particular areas that are prone to mismatch are areas of repetitive DNA, that creates a little bubble in the DNA where it's not properly aligned. Normally, that extra DNA needs to be cut and repaired prior to the next round of replication. So each strand, which will serve as a template to replicate DNA, will faithfully create 2 copies that are identical to the original. If this doesn't get repaired in time before the next round of replication, one strand is a little bit longer than the other, creating one daughter cell with a copy of this area that is different than the original. And that can be seen, this is what's called microsatellite testing. Microsatellites are just simply areas of the genome that have repetitive DNA, and there are hundreds of thousands of these. We For clinical purposes, test about 6 or 7. Look at the length of this repetitive sequence. For example, BAP25 in red is the normal length in a non-tumor tissue of a patient. Should be at around 120 repeats of this repetitive sequence. A sample from a tumor from the same patient shows that a proportion of cells in that tumor have fewer repeats for that repetitive sequence at around 110 or so. If you have 3 or more microsatellites that have a deviation from normal tissue, that tumor is microsatellite unstable, meaning it's mutating, it's expanding or contracting this repetitive sequence, and is due to damage in the mismatch repair machinery. And the mismatch repair machinery is basically the genes that are responsible for Lynch syndrome. There are 4 genes. First, you got to recognize there is a mismatch, and remember the letter S in mismatch. And these are the mut S proteins, S for mismatch, MSH2 and 6. They recognize the bubble of a mismatch base pair, and that leads to the excision, the local cut of that extra DNA, and then the repair prior to replication. And that's mediated by MLH1 with its partner PMS2. L for MLH. So when any of these factors are mutated or otherwise damaged, mismatch repair does not take place and microsatellite instability will ensue. So both chromosomal instability and MSI create broad damage to the genome, with the outcome being damaged gene function, initially randomly, but eventually through selection pressures. Cells that have an advantage due to the mutations that they've acquired start growing out of control. And that's what initiates the neoplastic process. How am I doing with time? Okay, I probably need to move a little faster here. So what are the pathways that are typically targeted by these pathways of genetic damage? Well, if what the cell is ultimately going to acquire is uncontrolled growth, these are pathways that normally control growth in the intestinal epithelium, which are now going to become abnormally hyperactive to endow these epithelial cells with uncontrolled growth. So it's important to point out 3 pathways that are normally involved. These are not the only ones, but these are important to understand the key drivers of cancer. 3 pathways are typically involved in controlling growth in the intestinal epithelium. The BMP pathway, which is most active at the top of the crypt or the villus in the small intestine, is involved in promoting differentiation of cells, whereas the Wnt pathway is involved at the bottom of the crypt in promoting exit from the stem cell zone and early proliferation. EGF, epidermal growth factor, is also involved in proliferation, promoting proliferation in the bottom of the crypt. So these are the pathways that are going to be dysregulated and lead to or facilitate tumor growth. So the Wnt pathway, it's a classical ligand receptor pathway. So there's a ligand called Wnt, various Wnt flavors, and a receptor. The name of the receptor is a funny name, Frizzle. These names are not that important for you to remember. The key effect when Wnt is around is to act on a molecule called beta-catenin. Beta-catenin, in the absence of Wnt, is constantly being degraded inside of the cell. When Wnt comes around, it stabilizes beta-catenin, allowing it to move to the nucleus, where it will activate transcription of genes that promote cell proliferation. So the constitutive degradation of beta-catenin is interrupted, allowing beta-catenin to accumulate and go into the nucleus. So things that can get mutated and lead to Wnt activation and in neoplastic proliferation typically target elements in this pathway. So the easiest ones to understand, and the most common, would be a mutation in APC, which is part of this destruction pathway, complex. So when APC is not around, this constitutive degradation of beta-catenin can't take place, and beta-catenin starts accumulating even though Wnt is not necessarily around in any increased amount. The partner of beta-catenin can also be mutated to make it more active. The frizzled receptor can be also mutated to make it more active, or beta-catenin itself can be mutated so it's not recognized by the destruction complex. I'm telling you about these other ones just so you understand the logic of how these things work. But the one that you really need to remember is the APC mutation. It is the most common mutation in colorectal cancer, and it's the gene that is responsible, if it's mutated at the germline, that is responsible for FAP. So APC is beta-catenin, which is normally minimally present in the cytosol, is mostly in the cell-to-cell border. So you see lines depicting the borders of cells in normal epithelium. When the Wnt pathway is active, it starts accumulating in the cell, and it accumulates particularly in the nucleus, and this is what you see in colon cancer, and then it drives expression of proliferative genes. The BMP pathway, on the other hand, which promotes differentiation and blocks the proliferative process, antiproliferative, is going to be targeted in the opposite direction. Rather than mutations that activate the BMP signaling pathway, like we saw for Wnt. Wnt is hyperactivated. Here, the mutations will inhibit BMP signaling. So the receptors can be mutated, or the signaling mediators inside of the cell that carry the signal that BMP executes are also going to be mutated and become inactive. EGF, another proliferative signal, can be hyperactivated. Sometimes this is due to an increased copy number for the receptor, so the cells express higher amounts of the receptor. Rarely there can be mutations in the receptor that make it constitutively active, but most commonly the mutations are in the downstream signaling mediators that EGF receptor is supposed to activate. So this can be the RAS molecule, which comes in two flavors, KRAS or NRAS, which are commonly mutated. Downstream of RAS is RAF, BRAF is commonly mutated, and so on. Now, it's important to point out that sometimes what's activated, or the way in which the gene function is abnormal, is not due to damaging the DNA itself, but sometimes damaging in the way in which the DNA activity is controlled, and that's something called epigenetics. So briefly, the DNA is wrapped around histones, and depending on how tightly wrapped it is, it can be in the heterochromatin state, where that DNA is essentially inaccessible and silenced. The genes cannot be read, and it's as though these genes are turned off, or wrapped around these histones in a very loose manner, or euchromatin. We can see that in microscopy, as you remember. And these genes, the DNA is accessible and the genes are active. So this process of how tightly packed the DNA is depends on modifications of the DNA itself, DNA methylation, and modifications of the chemistry of the histone proteins, a number of chemical modifications, the most common being acetylation, but many others as well. And depending on those marks, the DNA can be tightly packed or loosely packed. And this process can also be abnormal in cancer. So it's been recognized that there is a subgroup of colon cancers in which DNA methylation is hyperactive. For some reason, somebody decided to give it this acronym, CpG island methylator phenotype. It turns out that areas of CG repeats are most commonly DNA methylated. So CIMP just describes hypermethylation of DNA. About 15% of colon cancers have hypermethylation of DNA, which can, by epigenetic mechanisms, silence a number of genes, some which can be important for controlling growth. This is most commonly seen in the context of mutations of BRAF, so it's probably not the first change that initiates tumor development, but it certainly can accelerate it. Typically seen in the context of sessile-serrated adenomas, and a common target is the MLH1 gene, one of the genes involved in mismatch repair. So this abnormal methylation ends up getting compounded by loss of mismatch repair mechanisms, not because the mismatch repair pathway is mutated, but it's because it is silenced. And as a matter of fact, if one were to look at tumors with microsatellite instability, mutations in the mismatch repair genes are not the most common reason for it. It's actually this methylator phenotype that is more commonly responsible for the development of mismatch repair defects through silencing of this pathway. And this is why this epigenetic changes are important to mention. Okay, so bringing all of these different strands together to understand how tumor types within colon cancers come to be. So remember, there's one major driver, chromosomal instability, and another major driver, microsatellite instability. Microsatellite instability could be it's more often due to epigenetic silencing of genes in that are responsible for mismatch repair. So it turns out that these potential changes that can lead to abnormal growth in the epithelium don't occur randomly or all at once, but they occur sequentially, and certain sequences are going to occur more often than not because they collaborate with each other to endow this cell to now grow in an uncontrolled fashion. And that leads to altogether 4 main subclasses of colorectal cancer. And I'm going to try to now show you what those subclasses are and how that relates to the various pathways that we've been discussing in the last 45, 50 minutes. So let's start with a simple tumor types, or the simplest tumor types to understand. First, our tumors are arise due to a defect in microsatellite, mismatch repair resulting in microsatellite instability. The 2 reasons why an epithelial cell might acquire microsatellite instability might be Lynch mutations or mutations in those genes occurring somatically, or this DNA methylation abnormality leading to silencing of the mismatch repair pathway, typically at the level of one of these genes, the MLH1 gene. More rarely, mutations in other things involved in DNA replication, such as a polymerase epsilon mutation, can result in tumors that are hypermutated. So as I mentioned, the SIMP pathway is more common than Lynch or poly mutations. So the majority of these tumors are hypermutated and hypermethylated. And the tumor promoting genes that are going to be mutated classically have DNA repetitive sequences, which are most prone to this microsatellite instability type of change. These tumors have over 2,000 somatic changes. So compared to cells that are non-tumor in your body, if you had a tumor like this tumor type would have over 2,000 genes with tumor-associated mutations. As a result, they are highly immunogenic. They have a number of proteins with new coding sequence due to these mutations, and they are inflamed. And so this tumor type is called immune, but it's a microsatellite unstable tumor, many times hypermethylated, and most of the genes that are mutated have repetitive DNA sequences. Contrast this with the classical chromosomal unstable tumor. These tumors typically start with an APC mutation. We said that's about 75% of sporadic tumors have that. And it's compounded by mutations in other pathways that are related to growth, such as KRAS, downstream of EGF, PI3K, PIK3CA, this is in the PI3 kinase pathway, also downstream of that, SMAD4 in the BMP pathway, and so on. That's the so-called canonical tumor. Now, it turns out that chromosomally unstable tumors also can come in a couple of flavors that are subforms of this type of tumor, but are important in terms of clinical outcomes. Some are associated with changes in the TGF-beta pathway, and the cells are growing more like a fibroblast than an epithelial cell. These are called so-called mesenchymal tumors, and they're more aggressive. They're more likely to metastasize, where others are dominated by the metabolic effects of the growth factor pathways, KRAS and others, and they're called this called metabolic phenotype. This tumor has implications as far as choices of drugs for treatment in the metastatic state. If you remember the immunocanonical and what drives it, I think I've done my job. These other two are less important unless you really want to understand colon cancer in more detail. This table highlights in more detail, especially the differences between these two other types and the immune and canonical. Just to bring it all together with other elements we discussed in the lecture, I want to point out that the first type, or the immune type, the classical precursor lesion is the sessile serrated adenoma. So these tumors are more likely to be, the sessile serrated adenomas are more likely to have DNA methylation, changes in microsatellite length, in lack of mismatch repair. Whereas the canonical tumors are typically coming from a tubular adenoma. So a tubular adenoma already is likely to be aneuploid, have chromosomal instability, and classically these have APC mutations already. Okay, so these are the key take-home points. We talked about risk factors, epidemiological trends. We talked about the genomic changes that drive the accumulation of mutations that will give rise to uncontrolled growth, chromosomal instability being the more common one, microsatellite instability being the less common one. Remember that epigenetic reprogramming through methylation can damage the way in which genes function, targeting often the mismatch repair pathway. We talked about growth, how growth control becomes a target, giving rise to uncontrolled tumor growth. We have 4 minutes. I had prepared 4 questions. We'll try to go through them quickly. And I'm not going to call on anybody. I'm just going to read the questions and tell you which ones are correct and which ones are incorrect and why. So please pick the correct statement. The lifetime risk of colon cancer in the US is 1 in 50. No, that's incorrect. It's really 1 in 20 or 6%. So it's higher than what's listed here. Organ transplantation, diabetes, obesity, acromegaly, and IBD increase the risk of CRC. That seems to be correct. FAP is the most common genetic syndrome associated with colon cancer. That is not true. That would be Lynch. red meat and fish consumption decrease CRC risk. That's not correct. Fish consumption does, red meat increases your risk. African Americans have an increased risk of CRC, which is due to the high risk of CRC in people of African descent. It is not genetic. We talked about the difference between cancer risk in Africa and in the United States and the environmental factors potentially behind that. So B is the correct answer. Which lesion corresponds to a sessile serrated adenoma? I think you can see the lesion on the right is a bunch of glands that are bluer than the rest of the epithelium. Blue, that's an adenoma, and it's due to mucin depletion, so this is not it. These two lesions are similar. They're both serrated. This one has crypts that are parallel to each other and well spaced, and there's nothing abnormal about the glandular lumen, whereas the lesion on the left in A has this glandular dilation at the bottom, and you can actually even see some dysplasia here, pseudostratification of the nuclei. So this one is your SSA, okay? SSA, hyperplastic polyp, tubular adenoma. Okay, so pick the correct statement. What you're seeing here is an aneuploid karyotype, multiple copies of some genes and of some chromosomes, sorry, and some chromosomes which are the result of the fusion of pieces of original chromosomes. This is chromosomal instability. So let's now read what the questions are. This karyotype is characteristic of a Lynch syndrome associated tumor. That would be incorrect. Lynch syndrome gives you microsatellite instability with a diploid tumor or largely diploid tumor without aneuploidy. This karyotype is associated with hypermutation phenotype. That's also incorrect. That's what you see in microsatellite instability, which is again a diploid tumor. Loss of function mutations in APC are highly likely. Yes, we reviewed that at the very end. The canonical class of colon cancer is associated with chromosomal instability, and the most common mutation there is mutations in APC. A tubular adenoma is an unlikely precursor lesion for this cancer. That is incorrect. We said that canonical tumors typically come from tubular adenoma. So the right answer is C. Okay, regarding this tumor, pick the correct answer. So I'm showing you here beta-catenin staining. I showed you one earlier. And with the point of this is recognizing that beta-catenin, which is in the Wnt pathway, typically should be on the border of the cell and very little inside of the cell because it's typically being degraded all the time. That's the function of APC. When that's not there, it will accumulate in the nucleus. Mutation in TGF-beta receptor 2 is highly likely. That's not true, and this is tough. This is a tough question, but it's in the last slide. That's more commonly seen in the MSI tumors. But even if you didn't know that, you should be able to get the answer correctly. The staining pattern suggests loss of APC or a mutation in CTNNB1. Okay, loss of APC. Clearly, we just said that that's the most common reason why beta-catenin will accumulate and go into the nucleus. This is the gene that makes beta-catenin. There are some mutations in cancer that make beta-catenin unrecognizable to that destruction complex, and that's how it becomes stable. So that's going to be the correct answer. The SMAD4 mutations are seen in the inflammatory MSI high tumor. So answer is B. And I think this is my last question. Ben, should I finish this or am I too far out of time?
You're fine. You can continue.
Okay. Okay. Which one is correct about these tumor subtypes? So the immune subtype is likely to be more immunogenic due to the high number of mutations and neoantigens. That sounds right? Based on the discussion we had, how these tumors have about 2,000 mutations in genes, and they are at baseline already inflammatory. Just as a point of perspective, the canonical subtype, which was the other main subtype I was discussing with you, that has maybe 100 to 150 somatic mutations. So this is maybe 20 times, 15 to 20 times more mutated. And that's the driver for the inflammatory histology and the so-called immune type that has been described for this tumor. As a result, these tumors have a high response rate to tumor immunotherapy. I didn't tell you this, but it seems reasonable, and it is true that tumor immunotherapy is a lot more effective in immune type tumors, even in the context of metastasis. So that's an important corollary between understanding the underlying molecular events, the tumor classification, how that informs therapy. Mesenchymal types have worse prognosis and a tendency to metastasize. We briefly mentioned that, and that is also true. Metabolic type have a higher likelihood of KRAS and EGFR mutations. We also briefly said that this is a type that has all the growth activities of the EGF pathway turned on and a number of metabolic hallmarks of that. So all of these are correct. This is the last question. Yes, this is the last question. So I'll ask it. A tumor in the right colon with MSI high may be due to a germline mutation in the mismatch repair gene. Yes, it may be. It turns out the Lynch-associated tumors are more likely to be on the right. If you didn't know the answer to that, all you gotta remember is the MSI high tumors, or these immune subtype, are the precursor lesion is the sessile serrated adenoma, which is more likely to be present in the right colon. So if you put all of those elements together, you should be able to deduce this and get this. They got that part right. Now, the part that is incorrect is that it's not most commonly due to a germline mutation, but the most common mechanism for MSI high is the methylator phenotype, is the CIMP tumors. They're more common than the Lynch tumors by a factor of 2 to 1. So while the first part of this is correct, the statement of germline mutations in mismatch repair genes is incorrect. Therefore, this one is overall incorrect. More often, MSI high tumor is due to somatic inactivation of the mismatch repair system. That is correct. Okay, I guess it says maybe due, no, most commonly due. So if we read this as maybe due, the choice A can be also correct. Sorry, I don't mean to confuse you, but all these words mean something. So maybe makes it correct instead of it's often due to. So this one is correct. This is what we were talking about, the CIMP mutation being, the CIMP pathway being more common. The most common mechanism for mismatch repair inactivation is MLH1 hypermethylation and silencing. We went over that, and that is correct. It's most commonly seen in BRAF mutated tumors. That is also correct. This is deep in the weeds of cancer pathogenesis, but it reviews a lot of those concepts. The precursor lesion for MSI high CMS1 tumor is a tubular adenoma. We just went over that. And clearly that is not correct. The precursor lesion is an SSA. So if you got to choose an incorrect statement, this would be it. All right, so I'm 6 minutes over time. Sorry, guys. Hopefully this was helpful. If you have any questions, I guess you can shoot me an email. I'll be more than happy to entertain any question you have.
Awesome. Thank you so much for your time this morning, Dr. Burstein.
Absolutely. Take care, guys. Have a good day.